and a warm welcome and big thanks to everyone for joining us here today. It is with great pleasure that I introduce you to our speaker, Rema Nagarajan. Rema is a senior journalist and has been covering topics related to medical practice and healthcare provision in India for over 2 decades. Her work on the privatization of medical education and on the regulation of private hospitals has helped reveal the complex ways in which health policy is designed and implemented. Rema was a Fulbright scholar in 2005 when she undertook a study on data journalism. In 2012, as a Nieman Global Health Reporting Fellow, Rema worked with the Pulitzer Center for Crisis Reporting. She has recently completed a chapter for the book COVID from the Margins, which analyzes India's response to the virus. Over the past year and a half, the Center for Contemporary South Asia has organized various events on COVID in South Asia. It is an honor to have Rema here with us today. Her long engagement with healthcare will help us understand the issues that shape the pandemic in India. Rema will speak for 40 minutes, following which we will invite questions from the audience. At that point, you can use the hand raise function on Zoom, and I'll call on you to ask your question. Thank you.
Hi, shall I share my screen now?
Yes.
Hi, everybody. I'm going to talk about private healthcare sector in India and its response to COVID, but more specifically, it will be about private hospitals, mainly because it is private hospitals that provide the bulk of healthcare in India. About 2/3 of health services are provided by the private sector. And during COVID, it was no different. They were providing most of the care even during COVID. And please don't get distracted by the fact that I'm going to check my notes once in a while. So I'm going to turn away from the screen a little bit. And what we saw during COVID was no different from what we saw before that in the way the private sector behaved or in the way it responded to the crisis. And COVID merely exposed and laid bare what patients knew all along, and which the government has steadfastly refused to acknowledge, which is that there is zero regulation of the private sector in India, especially the hospital sector. And there seems to be very little will or the capacity to be regulating this sector. Now, when we say private sector, let's take a look at what exactly it means. Oh, my screen is stuck. So, it's a whole lot of things. For example, there are the pharmaceutical companies that produce the drugs. There are medical device companies, manufacturers of various consumables, protective equipment, ambulance operators. All of these actors in the private health sector, we saw the way they indulged in price gouging during COVID. And one of the reasons was because the patients were left to individually negotiate with these people to buy their whatever was needed for them during COVID, all the medical essentials that they had to buy. And when you go in and individually negotiate, that also meant that they had very little negotiating power, and most of them were looted. Now, one space where all the actors come together is hospitals. And that's also the place where the sickest, the most desperate patients reach seeking healthcare. And that is exactly and with the state, not exactly being able to provide all of the healthcare, it is private hospitals which stepped in. Unfortunately for patients, 60% of inpatient beds in India is in the private sector, and 85% of tertiary care beds are also with the private sector. So that leaves the public health guys, providing barely 1/3 of inpatient services, and which basically, answers the question which people often ask patients who go to the private sector: if you cannot afford it, why do you go to a private hospital? Why should you even go there? The answer is because, that's where the services are, and the government services are not enough to provide for everybody. So people are often forced to go to the private sector, knowing fully well that they will be impoverishing themselves in the bargain. And private sector, even during COVID, had claimed that they had done 70% of COVID care. They were boasting about the fact that, how much the country was dependent on them for providing the care. But here, I think we should step back a little and examine if that is completely true, that statement that they provided 70% of COVID care, because that statement comes from a completely curative and extractive view of healthcare. All that the private sector cares about is the curative side of healthcare. There's almost zero focus on prevention. And we know very well that in COVID, a large part of our strategy was prevention. And if there was no preventive strategy in COVID, we would have had thousands and thousands more patients coming into the health system, and the health system would have collapsed long before we did see it collapse in the second wave. That would have happened much, much before that if there had been no prevention strategies at all. And the prevention strategies such as tracing, tracking, isolating of patients, educating patients, all of these preventive activities were 100% done by the public sector. That's also because private sector is not really interested in preventive healthcare because it has never been lucrative enough for them. And a great example of that is vaccination, with the Indian government trying very hard to encourage the private sector and trying to sort of woo them to take part in the vaccination process. But they ended up vaccinating barely 7% of all the vaccinations done in the country. And that shouldn't surprise us because when the prices are regulated as it was done for vaccination, mostly private sectors are not interested, and their reach is also very limited. They're mostly restricted to the cities. Now, going to the next slide, let's look at the private hospital sector a little more closely. What do we mean by this? So as you can see, 80% of the private sector is really small. These are all small hospitals and nursing homes. They are barely like 10 beds, 15 beds, those kind of hospitals. And they don't have ICU care. They didn't have the facilities needed to take care of COVID patients. They didn't have the means to, have separation for COVID and non-COVID care. They couldn't access PPEs for their staff. So most of them just shut shop, which meant that about 80% of your private health system actually, just closed down because they couldn't deal with the pandemic. And the rest of them, which is 13 plus 8, roughly about 20%, those are the ones which were roped in for COVID care. And even these hospitals found the going extremely tough because most of them, their revenue stream, so to speak, depended on elective surgeries and outpatient department. Both these were banned during COVID after the first 2 months by the government itself, which meant that their revenue streams dried up. And they were not interested in treating COVID because they were very scared that it's such an infectious disease. If COVID patients come to their hospitals, that would chase away the rest of their business. Till actually the elective surgeries also dried up and there were no OPD facilities. So that's when they finally decided that maybe they should be looking at, taking care of COVID patients. Now, private sector, for them, they can shut shop saying that, it's not lucrative enough for us, or, our business cannot run, because for them, finally, it's about survival and their main mandate is about making profit. The government cannot afford to do that, or at least we hope that's not the mandate of the government. So the two sectors have completely different mandates. One is focused on their survival and about making profits, whereas the government is focused on actually providing healthcare to the people. How well it does that, that's of course debatable. Now, coming back to the private sector and the 50 bedded hospitals, which are the bulk of them, 50 plus bedded hospitals, which are the smaller percentage of them, those were the ones which finally had to be almost pulled into COVID care through threats, through diktats, with the government issuing advisories. And finally, when they did, and they came in, we started seeing lots and lots of cases of overcharging, inappropriate treatment, and the private sector, I think, took it quite literally when the Prime Minister said "Aapda mein avsar," which basically means opportunity in disaster. They decided to turn the opportunity into a disaster in earnest. And one of the things that they looked at was PPE, which was something new for hospitals. So the markups were huge. They formed almost a third of the bill sometimes. They were overcharging on PPE, and this is just one of the items that we are looking at. There was overcharging on just about everything, but that's nothing new because they've always overcharged on everything. But PPE was their focus because this was a new thing that they could make a lot of money on. And the government kept saying that they're violating government norms, but that's about it. The government brought in regulations. As you can see on the left side of the screen, that it's the central government, the Home Minister, the all-powerful Home Ministry, which constituted a committee, and they decided to fix the charges for beds in Delhi. And some state governments like Kerala, for example, fixed the price for PPE too. But most of these cases, what happened was, though they were regulations, there were so many loopholes and exemptions, even in the way the prices were fixed, and with little monitoring, that it didn't quite work out the way it was supposed to work out. Now, was this something new? Should we be surprised that the regulations didn't work, or that they flouted the regulation? No, I don't think so, because let's take a look at what it was like in 2018. It was the same. We had stories of huge medical bills, overcharging, so many hospitals across the country. We have courts intervening to little effect. So this is nothing new, in that sense. There was no difference in the behavior of the private sector, whether it was a pandemic or a regular business as usual. And did the government not know what was happening? Let's take a look. Now, this headline about private hospitals making profits of up to 1,737% on drugs. This comes from an audit of a couple of hospitals' bills, which was done by the National Pharmaceutical Pricing Authority. There was a complaint against these hospitals. This NPPA, this body, decided to audit their bills, and they found that hospitals were making enormous profits on just about everything you can think of, from a glove to a syringe to stents, implants, drugs of all kinds. In fact, the NPPA also noted that hospitals were actually encouraging industries to print higher prices so that the hospitals can buy them in bulk at a very low price and sell them for huge margins. All of this was known to the government. As you can see, this was done in 2018. Nothing was done about it, so things went on as usual. We have SC, as in Supreme Court, commenting on it, but nothing much happened beyond this. And it's not just hospitals which were doing this during COVID. Every kind of, there were ambulances, there were diagnostics. For example, let's take a look at some of the things the ambulance operators were doing. Now, this is an IPS officer, an Indian Police Service officer, who tweeted this bill for 10,000 rupees for traveling from barely like 4 kilometers. This would be enough to travel from Delhi to Kerala. I mean, you can fly from Delhi to Kerala, which is about 2,600 kilometers away, for this amount of money. Here's another one, 1.2 lakh, which is about 120,000 rupees from a patient's daughter. This was for traveling from Gurgaon to Ludhiana, which was about 350 kilometers. For this amount of money, you can actually fly to US and come back. There was very little regulation, despite many governments actually bringing in caps on how much ambulances could charge. It was the same with diagnostics. Twitter was full of this. People were complaining. The Odisha government had fixed the RT-PCR test at rupees 400. This particular hospital is charging 2,600 for it. This is at the Delhi airport. So obviously in control, I mean, the government knows what's happening and this is very much in government control. Here, RT-PCR tests, people were being charged rupees 5,000 for it. That's exorbitant. A lot of people, I mean, as you can see from the street, they said some passengers could not board because they could not afford to take that test. So it's not just about hospitals, I mean, just about every sector that you can think of was doing this. Now, the question is, why would people go to the private sector? One reason is, like I explained at the beginning, the bulk of healthcare services are in the private sector, so you don't have an option. The other one is the impression that, private sector offers better quality treatment. That's not necessarily true, though it's a very widespread and widely accepted notion. Lots of studies have shown that's not true, and COVID showed that too. For example, we had private hospitals promoting plasma therapy, knowing fully well that it doesn't necessarily hold some sort of magic spell power to cure everyone, but that's the way they made it out to be. Every kind of experimental drug that came into the market was being prescribed and given to patients. And one of the reasons for that was the government was not putting a cap on the price for experimental drugs. So you will find it in a lot of bills of COVID patients that there were these drugs being given to them. Remdesivir, favipiravir. And what did the government do about it? Well, nothing much, because government was as much a part of it. Government did not want to seem as if they were helpless. So they promoted it actively. And here is one example. This is the health minister of Delhi. Even after the top medical research body of the country, Indian Council for Medical Research, finished its trial and showed that plasma is not necessarily working. It doesn't make any difference whether you give plasma or not. He told ICMR, which is the Indian Council for Medical Research, that they should actually not remove plasma from the protocol for treatment. So we had a lot of, it's not just in Delhi, Minister, we had a lot of politicians who were doing this. We had a lot of governments which were doing this. So the people were the ones who paid a price for this sort of irresponsible statements being issued by government officials as well as leaders, political leaders. And now we come to, the actual, what kind of private sector do we have here? Private sector is fantastic as long as, you have enough money. And they look lovely because it's all marble, it's air conditioned, it's everybody's smiling and talking to you very nicely. But this lasts only as long as you have money. The moment you run out of money or you question their treatment, then you see a completely different side of the private sector or private hospitals. And that's exactly what happened even during COVID. For example, government was setting aside beds, asking hospitals to reserve beds for patients, COVID patients. And not only were they overcharging, they were also claiming that, though the beds are vacant, they were claiming that there are no beds available. Here you have, hospitals holding patients hostage because they could not pay the bill. So you would not be allowed to leave the hospital till you paid the bill. And you can't, dispute the bill with them at that point of time. This is despite so many courts having ruled against this and saying that this is illegal. Again, another patient they had done wrong billing. The patient asked for a refund. He even got a refund, but the refund, he was being offered the refund on the condition that he will not talk to the media about it. So he was asked to sign a disclosure agreement. He refused. That's a different story, but those are the kind of things that hospitals do. Yeah, this is across the country. Hyderabad, Delhi, Bombay, you name it. Every city has seen this. Across the country, we have seen this. Here is a case of a hospital keeping the body of the patient, refusing to release it because the doctor could not pay the bills. Now, you might wonder if this is happening only during COVID, because it was a desperate situation. Hospitals had also faced a cash crunch, a revenue flow problem. No, not necessarily. This is something which has been happening even before COVID. So it's not about COVID. So yeah, even if you have insurance, this is what happens. I mean, till if the insurer refuses to cover the bill, then the patient gets held hostage. Now let's take a look at what was happening before COVID. This is a story from 2017, where the Delhi High Court is ruling that you cannot hold patient hostage. This is on a case where a patient had been held hostage. So this is kind of a common modus operandi for most hospitals. Private hospitals, they turn pretty nasty if you cannot pay the bill. Yeah. This is 2018 story, again saying that, you cannot hold patients hostage. This is right during COVID. This is October 2020. The same thing was happening and the High Court had to intervene. So, nothing quite changes and you wonder why. It's because, there is very little that they have to fear in terms of they don't face any consequence for breaking the law or not listening to the courts. So they continue to do what they've always been doing, and that's exactly what they did during COVID too. And you think that, if this is what they did in the middle of a pandemic, imagine what they must be doing otherwise. So here I'm giving you an example of when some of the governments of some of the states and even cities, they decided to do an audit of the hospital bills. You can see the amount of effort that goes into doing an audit. There were 5 administrative officers, 17 auditors, all of them were roped in to actually monitor the private hospitals. And these are some of the things which they found. If you're given one drug, you're charged for the entire strip. One PPE is used by doctors or nurses for 10 patients, but each patient will be, charged for the same PPE separately. And all of those things which were listed by National Pharmaceutical Pricing Authority in the 2018 audit that they had done, the same thing was happening during COVID too. And you would think that that would make a regular case for, that would make a case for regular auditing of bills. But no, we don't see anything of the kind. In fact, take a look at some of the things that turned up when they actually did the auditing. Hospitals charged the patients, as in they took the money from the patient, and for the same patient, they would seek reimbursement from the government. That's Pune, where inflated bills, they found 2.86 crore was charged to patients over billing. They inspected over 6,000 bills and they found that 14 crores had to be refunded to the patient. This is like a fraction of what the total, when you look at the fact that lakhs of people were seeking treatment, and here is a government looking at a mere 6,000 bills and finding that there was overbilling to the tune of 14 crore. And you're trying to get it refunded for the patient, but you still don't think that, auditing should become a regular part of regulating private sector. And what was the private sector's reaction to this? The private sector's reaction is pretty, standard, because they realize that if this becomes the norm, that they're going to get regulated. They've got so used to not being regulated that when government started capping the price of things which are used in the hospital, which meant beds and drugs and things like that, the private hospital said that not financially sustainable. We will not be able to survive. Despite the price cap that the government did, you can just take a look at, 2-day stay in ICU cost him 170,000 rupees. And this is a daily wager patient in a private hospital. So in effect, you have basically indebted him for God knows how many years to come. This was another kind of resistance to regulation that hospitals were doing. The government had told hospitals that they need to show how many beds are free so that they could update that information on their dashboard so that people would know which hospital to go to when they need to find a bed. But they were not updating those dashboard. And 2 is when the patient reaches there, they say the bed is not available. Bangalore, it was the same thing. And the government, as you can see, the government is saying that, the shortage isn't about availability, but the hospitals are flouting the rules. That's very nice, the government saying all these things. The point is, if the government is saying this, where does that leave the people? And mostly people were left running from one hospital to another looking for a bed. And most of the time, the hospitals would refuse to admit them. The government also made the mistake of regulating prices on only a certain percentage of beds. And if you reach a hospital, most hospitals would tell you that there are no beds available which are regulated. So you don't have an option. I mean, patients had absolutely no option but to take whatever was offered to them. And the governments were of very little help because government kept saying that, the government had no option because, they themselves, their own facilities were not enough to deal with COVID. So they had no option but to rope in the private sector. So they would, issue a few threats and say that, they would shut them down, they would stop them from treating COVID. They did it in a few cases. But, within a few weeks, the hospital would be back in operation simply because the government could not afford to do that. Yeah, I mean, the hospitals have taken the government to court. This is Nagpur Municipal Corporation. The Hospital Association took the government to court for auditing their bills because hospitals realize that if audits become a part of regular regulation, they are going to face a lot of problems. So they're making sure that that doesn't happen. They've got a stay from the court on auditing of their bills. Now let's see, what was the effect of actually government capping the prices? Capped prices we would think would help the people, but let's take a look at, what was the capped prices versus, how much people actually earn. Now, this is a study done by people in the Public Health Foundation of India. So number of work days required to pay for the cost of, say, testing or home isolation, hospital isolation, and what they found was this. 10 days of COVID ICU cost, and when I say cost, this is the capped price, the regulated price, that is equivalent to 7 months pay for an average Indian. So if you have had one spell of COVID where you need to be in the ICU for 10 days, that means whatever you earn for 7 months, you're going to end up paying to the hospital. And most cases, people stayed much longer. The average length of stay was about 2 weeks in an ICU if you were badly off. This is a sort of analysis that we had done in Times of India, where we looked at the monthly spend of families in different states. This is mostly in the rural areas that we are looking at. And if you look at it, the monthly spend of 80% of families, it is so low that most of them would not be able to afford even the capped prices that the government had brought into effect. So I don't know what the government was thinking when they said that they're capping prices, because we needed capping of prices, we needed regulation, but none of that was actually going to make it affordable to the people. Yeah, so hospitals cost capped, but COVID would still cripple about 80% of the families. The other thing is, let's take a look at some of the other figures on monthly income. As you can see, bottom 10%, $22. 10 to 50% of Indian households, $64. So, with so much poverty, no amount of capping is going to make health affordable. What would be needed is free healthcare. But that's something that, was available only in public health, public hospitals. No matter which calculation you look at, you can look at the National Survey on Expenditure, you can look at, Piketty's data, whichever one you look at, there's no way that 80% of this country can afford even the capped charges. So, which goes to show that none of this would have made much of a difference to people, and that was pretty obvious even during COVID, as you will see from the next slide. This is even before COVID, as you can see. Healthcare is one of the main reasons why people are pushed into poverty. We have 55 million people being pushed into poverty because of healthcare expenditure. This was in 2011-12. COVID is supposed to have pushed 23 crore Indians into poverty. Yeah, so people turn to online fundraisers. When we say online fundraisers, we are talking about a very middle class population or the upper class, which knows about fundraisers and doing them. But for most of the others, this is what it meant. It meant selling property. It meant selling your jewelry, taking loans which you could not afford to pay back, basically getting indebted. So with all the capping of prices and regulation that the government did, which was full of holes and loopholes, this is what it resulted in. And there's a reason why, the government is never quite bothered about the cost of treatment. If you look at it, most of the leaders are getting treated in the private sector. All their medical bills are paid with public money. So they never have to worry about how much it costs to get treated because taxpayers' money is used to treat them. And this is not about just the leaders who are mentioned on the slide. It's just about every single political leader, judges, bureaucrats, all of them have a scheme in place, which means that they don't pay anything. All of it is footed by the government, which basically means public funds. So they have zero sort of skin in the game. They don't really need to worry about the fact that people cannot afford healthcare because their own healthcare is never a point of worry for them. Now this was an insurance scheme which the government brought in, Ayushman Bharat. This is supposed to cover the poorest people in the country. It's a huge scheme and it takes care of only inpatient care, not for outpatients. But as you can see, this hasn't really worked all that well. This is an RTI reply, which the government gave when they were asked how many people avail treatment under the scheme of Ayushman Bharat in the various states. Treatment count is here. And in a state like Bihar, for example, which is such a huge population, 19 people got treated, 19, when they had lakhs of COVID patients. So yeah, 20 lakh. So they are boasting that they did 20 lakh tests and 7.25 lakh COVID related treatment in a country where, millions of people were running around looking for treatment. And this is just from April to July. And it's not just, the government insurance scheme of Ayushman Bharat, even the private sector insurance too. A lot of middle class and upper middle class people and upper class people thought, I have insurance, I don't need to worry. In most cases, they found the insurance wasn't enough. So yeah, it was an uphill task to get any sort of medical insurance. Large number of them couldn't get hospital beds. A lot of them had to arrange for a lot of treatment at home. And then they get to hear from the insurance company that, you will not get it because we only pay for the hospitalization. So, health insurance is not always working in the favor of the patient. And this is the court itself saying it. So this is in response to people who went to court, hoping that they would get some respite from there. So Ayushman Bharat, private health insurance, none of this really worked in COVID. And we could see that, the government could see this, they have the data. And you would think that the government can see that what we need is an expansion of the public health system, which can offer free healthcare to people. And, hopefully they can also improve the quality. Government has been talking about improving the quality of healthcare by giving more funds to it. But what we have is this. And this came out, this report of Niti Aayog, which is the body which does planning for the country. Niti Aayog released a report on March 30, 2021, talking about healthcare investment. Basically, we have privatization on steroids in the middle of, bang in the middle of COVID, after having seen what private hospitals did to COVID patients and responded to the crisis. Industry status for hospitals. They want PPP model, because they want every private medical college to be linked to the district hospitals, which basically means hand over your district hospitals, which are built with public money, to private medical colleges to be used as teaching hospitals. So yeah, this is Ministry and the Niti Aayog. Niti Aayog is merely reflecting what this government's intent is, which is that they think the answer to all the problems is privatization, despite what they saw happening in COVID, which is kind of shocking. And this is during COVID, we all thought that after seeing what had happened, there would be a rethink on the part of the government. Everybody had expected that we would look at healthcare in a new way. There was a lot of talk about building back better and new normal. Really? I mean, we'll have to see how that works out. Thank you.
Thank you, Rina, for the expansive talk. So I'll just open up the floor for questions. People can perhaps raise their hands, and we'll get started. Okay, I think I'll start by asking the first question, which is basically, how do you see this stopping? Do you think that the private sector needs to be regulated, or do you think the public sector in India needs to be expanded? Are those the two options, or what else can be done?
It cannot be either or in the case of India, because already the private sector, the for-profit private sector is so dominant that it cannot be a switch overnight. So while we talk about, so we do need at the present situation, we do need to purchase some amount of services from the private sector. I don't think India has an option to completely shut out the private sector at this point of time. But at the same time, we also need to have a very clear roadmap of what we want to do with our public health system in terms of strengthening it. One of the examples is Tamil Nadu. It's a state in South India where what they have done is they have an insurance system where the state government actually pays for the treatment of people in private hospitals. But every year, there's a very close study by the policymakers of the data that comes back. They look at what they have paid the most for, where is the demand, what are they spending the most on. And for example, in 1 year, they found that a lot of kidney stone problems are being sent to the private sector. They asked why the public sector cannot deal with something so simple. And they found that public sector does not have lithotripsy machines. So the next year's budget, they made sure that they set aside money to buy lithotripsy machine for public sector hospitals. So those are the kind of things you could possibly do, that while you are purchasing from the private sector, you could look at what needs to be strengthened in the public sector, how you could actually boost it. But along with that, since you become, if you are using health insurance and you become the major purchaser for health services, you need to have some sort of regulation on how the private sector functions. And that is what seems to be missing. And I think that's mainly missing because, like I said, nobody who's in power needs to pay for their healthcare. So they don't really care about, and they get treated extremely well when they go to the private sector, because their bills are, no matter how big they are, gets cleared. So private sector loves them. Private sector loves people who come with blank checks. So they don't see the kind of problems that normal people face when they walk into a private hospital. So yeah, I think so. It has to be a combination of both private sector. I mean, purchasing some services from the private sector, but you need to be clear about where you're going with that, and simultaneously strengthen your public sector so that there you have some more bargaining power. If you're completely going to sell out to the private sector, at some point they are not going to let you bargain.
It is a follow-up question on the same. So the politicians and the bureaucrats are not being asked to pay the bills, so they don't look at the bills and are not bothered by them. But why are the constituents not raising their voices? I mean, there was so much, as you documented, on the internet, on Twitter, and also all of social media. And despite that, in the upcoming UP elections, I don't see any talk here about healthcare costs and the number of families who've been driven into poverty because of COVID specifically.
Uh, if you are as poor as a large section of the population is in India, like you saw those tables showing how much the monthly income of most people is, if you are as poor as that, often you have to choose what's your priority going to be. So it could be that, everyday things are more important than health emergencies, which happen once in a while. So everyday things like, schooling might be a problem, water might be a problem, electricity might be a problem, but health emergency for some reason, because it doesn't happen every day, and even if it happened to you, once it is over, you sort of tend to, I think, forget how bad it was and try to move on. But having said that, it's not as if it is not an issue. It's important to people. I mean, it matters to people. But it's a lot like asking people in US, you pay the highest amount for medicines, and people want to change that. Why is it that people are not able to change that? The reason why people are not able to change that is because our democracies are flawed right now. What people want is not being reflected in the way our legislators function, in the way our legislative function. That problem exists in the US, and I see that problem increasingly becoming the biggest problem in India. And I think one of the reasons is because no sort of funding. A lot of political funding is now coming from the private sector. This was never the case in India, but with electoral bonds in India, that's going to become a huge issue, just like in the US, where you will find your legislators are sold to the people who funded the election and not to the people who are voting for you. So I think, yeah, the problems that we are facing in that way are a lot similar to what people in the US are facing in wanting things to change, but not being able to convince their politicians to do much about it.
Okay. I don't see any questions from the audience yet. So maybe I'll wait for a minute. Let's see if someone raises their hand or sends me a chat message. Okay, Bhanu, can you go ahead with your question, please?
Thank you, Rema, for the presentation. I learned a lot. I have a couple of questions. So, one is on the regulation of private medical hospitals in India. I was wondering if you could help me understand how does the state regulate private sector, particularly medical institutions in India. The slide on your presentation seemed to be about audits being done by city government, so Pune Corporation and the Brihan Mumbai Municipal Corporation. But I was wondering if there's an expansive regulatory framework at the state or at the national level. So that's question one. And the second question is, I mean, healthcare in India doesn't look very different from the US in some sense. And I was wondering if there is a fundamental sort of difference in terms of what the Indian state thinks would the role of the state and the capital would be in a sector like health. And I see that the Indian state is ambivalent to health, education, housing. We don't know whether there's a vision from the state. So I was wondering if you could highlight being in this field, give me a 30,000 sort of view on what does this government, or at least what do practitioners within the government or outside the government think of uh, what healthcare in India should look like? Should it be entirely private? Should it be private plus insurance? Should it be well-regulated insurance and private sector? Should it be completely sort of public? So I just wanted to get a sort of broader 30,000 feet view on that. So those two questions. Thank you very much.
Thanks. I'll answer the last one first. That what does the government think of? I mean, what is their vision for healthcare? Well, we have to go to the national health policy, which is the latest national health policy for that. If you look at the national health policy, it's very clear that the way forward is increased privatization as far as this government is concerned. And I think that comes from, if you rewind to 1990s and liberalization that happened in India, we liberalized and we said government needs to get out of various sectors. Government shouldn't be in the business of business. And at that point of time, we were told that the reason why government should get out of businesses like hotels and various other things is because they need to focus on the core sectors. And at that point of time, we were told the core sectors are things like health and education. So the assumption was we will liberalize, the government will get into doing the kind of stuff that they're supposed to do, which is health and education. But now we are seeing that, the 20, 30 years down the line, we have a government which says, which seems to look for greater privatization through what they call public-private partnership, which basically means the government doesn't want to say outright that it's privatizing, because I think that would be very unpopular with the people, because I think people have a pretty good sense of what happens in the private sector to them. That would be unpopular. So the government is not willing to say that they're privatizing, but they're calling it PPP. PPP in effect means, a lot of your public assets being handed over to the private sector for being run. So on the one hand, you have the government still talking about public sector. And I think the private sector is very keen that the government stays invested in health, but only invested in what they call primary health, which is a sector which the public sector the private has very little interest in, because it means going into the rural areas, doing, preventive work, which is not lucrative, which doesn't have much money in it. So they're quite happy to have the government take care of primary healthcare. But what they want is for the government to hand over everything else to them, especially tertiary care. It might seem to make a lot of sense, since public health wisdom is that 80% of what ails the country can be taken care of at the primary and secondary level. And it's probably only 10% which comes to the tertiary care level. But when we see what impoverishes families and the way people are pushed into debt because of tertiary care, not just primary and secondary, but hugely because of tertiary care, I don't think the government can turn away completely. And the government health insurance scheme hasn't shown the kind of impact that we would want it to show, like we would see in a Germany, or the kind of insurance systems they have in place there. That's also because Germany has a very tough regulation for private hospitals. Now that brings us to the question of what you were asking: what do state governments have in terms of regulating private sector? Because after all, health is supposed to be a state subject. Now, each state government is supposed to have enacted what they call a Clinical Establishments Act. Now, this Clinical Establishment Act is what is supposed to have regulated the hospital sector. Most states haven't enacted them, and the ones which have enacted them, they're pretty toothless, because there isn't enough in them in terms of auditing hospitals, seeing what, and auditing is not just in terms of the money. It's not just about auditing the bills. It's also in terms of auditing the kind of treatment that's being given. Is it rational? Is it appropriate? Was it necessary? These are the things which also need to be looked at. I mean, a random audit would be great, but that's something which no government has an appetite for. One of the most stringent laws we have for regulating private sector is supposed to be in West Bengal. But if you hear the stories that are coming out of West Bengal, we realize that the law is more on paper, and there's very little that actually has been done in terms of actually regulating the hospitals. So I don't know. I mean, people still have to file cases, and those can go on forever. Other than that, going to the government, even in a place like Delhi, where let's take the example of Delhi actually, because it's the capital of the country. In COVID, we had just 117 hospitals being involved in COVID treatment. And, with the might of the central government, the home ministry and everybody throwing their might behind the whole capping of cost and regulating of healthcare, they could do nothing. They could do nothing about ensuring that people got a bed. They could do nothing about ensuring that people were not looted. That says a lot about your ability to regulate or the private sector's ability to deflect that sort of regulation. Does that answer your question, Manu?
Yeah, thank you. It does. Thank you.
Rema, just to follow up on that. So the cases that you've highlighted of as Dhami noted in Pune and in Bombay, these are city councils that have taken up the charge of regulating or trying to find out what's happening inside the private hospitals when they look at the bills. So these officials are different from the state government officials, or what is happening at the local level that's different, seems to be different from the central level?
So in many cities, actually, they have the city corporations, which are the civic bodies. They are the ones who are in charge of a lot of the public health measures. So they also are the ones which give licenses and things like that for businesses. So that's why they would be the ones to actually take action within the city limits. But that doesn't mean that they have any jurisdiction outside the city. And most of the hospitals, like, I think the second or the third slide showed 8% hospitals in this country have more than 100 beds. And, most of those hospitals would be in the cities. There are very few large hospitals outside cities. So these hospitals would mostly be regulated by the city corporations. That's not to say that the state doesn't have the power to do it. It's just that, state doesn't have legislation that's capable of doing this.
Does it work to have cities take charge of the hospitals in their vicinity, at least in the urban areas, and do audits and set prices, or should this be decided at the central level or at the state level?
The problem is most of these corporations which are powerful and which actually have the mandate to do all these are in the metro cities, which would be like, there would be 4, 5, 6, maximum 8 such large cities. Within a state, there are so many other centers which would have hospitals and where people would be going. So it seems it is quite frustrating that, state governments don't do enough of regulation. And if you were to file a complaint, every state has a council, medical council to look into, cases of complaints against doctors. But there are very few grievance redressal mechanism if I have to complain against a hospital. And mostly, like I said, you complain against a hospital, those cases go nowhere. And one of the reasons for that is most of the people within the government are actually getting treated in these hospitals. And so there is a conflict of interest there. And they tend to be much kinder on the hospitals than they should be.
How much of the difficulty in regulating hospitals and specifically the prices that things cost when the hospital charges them is related to medical education and how medical education is provided in the country. I'm specifically thinking about how expensive it has become to become a doctor in India since a lot of private medical colleges have opened up. And I'm wondering whether the costs of medical education are somehow being uh, are now falling upon patients. Um, so I know of cases in which people have spent crores getting a medical degree and then have to work at a hospital to and I'm wondering if this is a channel that's being created that's sort of acting to speed or to maintain the high levels of hospital care, the cost of hospital care.
The doctors are not the ones who are actually making the decisions in most of these hospitals, at least most of the larger ones. And also what the government envisages, the hospital as an investment sector, where you're getting investors from abroad, for example. You have hedge funds investing in hospitals. In that kind of a situation, I don't think the doctors are the ones who are deciding how much to charge the patients or what should be the way to get more revenue. But having said that, when you make medical education expensive, what you basically do is the people who become doctors are people from only one section of society. And that section of society has little or no understanding of the reality of the country, of large parts of the country. So they are only bothered about if they come from a really the top 5% of the population or even top 1%, because if you have to pay crores for your education, you probably belong to 1% of the population. And that 1% has a lifestyle which needs to be supported. So they would expect returns on what, I mean, so they would expect sky high salaries when they come out. And that kind of, and if you talk to hospital managements, they say that doctors expect a high salary. And if they want that kind of a salary, they need to be earning that kind of money too, which basically means that you need to bring in that kind of business. So if a doctor is asking for a very high salary, then the hospital management feels totally justified in asking them to actually bring in that kind of business into the hospital to justify the kind of salary that they are being paid. So it's a sort of vicious cycle in that sense. But yeah, I mean, I think, again, it's uncanny how these things are so similar, because in US also, I think the doctors are hugely, they are paid much, much higher than what doctors are paid in, say, Europe, for example. And I think that does contribute to making healthcare expensive. But that is not the only reason, because as these bigger so-called investment companies get into more and more of the healthcare and they want to expand into tier 2 and 3 cities, we are going to see some serious problems there, because they would want to return on the investment. They are looking only at the bottom line.
So I think if there are no more questions from the audience, then I think I'll just ask one more, because so if we could go back to pre-COVID and given what we know now, so we've talked about how the public servants, bureaucrats, politicians don't have the incentive to intervene in the system because it works quite well for them. So where do you see the change, the positive change sort of coming from? If there was another a third wave or another virus, another pandemic, do you think what we saw earlier this year would be repeated, or do you think things would be different?
I would like to think it would be different, but to be honest, I don't think it will be very different. It will not be very different for most parts of the country. Simply because some of these changes that are required to make us more resilient are systemic changes. And I don't see again, I don't see the government willing to go that far. Let me give you a very simple example. For example, in the question about ambulance operators and how they were fleecing people during COVID. Now, in Kerala, for example, all the private ambulance operators were were contracted by the government. So if you were to call for an ambulance, you would actually, the government would be picking up the tab. So you never really paid for an ambulance in Kerala from your own pocket. It's the government which is paying for the ambulance because the government believes that it's the government's responsibility to provide patient transport. Now, the difference it makes when I am in a desperate situation and I'm calling an ambulance and I have zero bargaining power as an individual versus a state government which is contracting, let's say 3/4 or maybe 80% of all the ambulance operators of the state and saying that enter into a contract with us because we are the ones who are going to be paying the bills. So there we are not saying, we want the government to boost their ambulance numbers, but we are not saying government shouldn't contract services from outside. But when they do that, they need to do it in a way that makes sense to the people, and the people are saved this bother of, I don't know, there was desperate scenes in Delhi where people were calling for ambulances, there were none. They were asking for huge amounts of money. And it's not, I mean, even in rural India, it was heartbreaking, the kind of scenes that we saw. People who had to take back the bodies of their loved ones strapped to a cycle because, there was no hearse van to carry the body back to the village, things like that. These are avoidable, but do we see any sort of conversation today from the government side saying that, since we saw all this happening, maybe we should look at patient transport more seriously? I mean, I'm taking just one small aspect of it. No, we are not seeing anything of the kind. We are not seeing the government saying that we need to ask ourselves why the patient transport system didn't work. We don't see that happening in Delhi, the capital of the country. What to talk about faraway village in Uttar Pradesh or Bihar or Chhattisgarh? So that's why there's a feeling that if it happens again, we wouldn't be ready. We will probably go through the same thing all over again.
That's really sad to hear.
I'm sad to say that it's quite depressing and it's negative, but like I said, we have positive examples. We have states like Kerala and Tamil Nadu showing us that it's possible. We have these states showing us that what a frugal pandemic strategy can look like. These are not states which had as much resources as, say, a Germany or a European country, but they still managed to do a pretty decent job of providing healthcare to their people. So these are states which are showing us that it's possible. Himachal is a tiny state. I mean, it's so close to Delhi. They have done a pretty good job. So we have small islands within this country where things work. We just need to see how we can, replicate those things in other parts of the country. We don't need to go out of the country, and you don't need to go to Europe to see what works and try and, because, we don't have those resources. We need to look at more, like I said, more frugal pandemic strategies, which we have. It's just that, I don't know when we'll actually get around to learning anything from them.
Well, thank you so much, Rema, for joining us. I think this is it for today. And we look forward to your book. It's called COVID from the Margins. Yeah, and is the release date known yet, or do we know when it's going to be published or
out? I think it's all done. Probably by next month, it should be out.
Okay, great. Well, I really look forward to that. Thank you so much. Thank you, everyone, for joining us.